Good day. We're going to be talking about Chapter 7 today, which is our lifespan and development. Again, the National EMS Education Standard competencies are found on the first page of the chapter in your textbook. You want to go over them because that's where your NREMT questions, and if you use FISDEP, that's where the FISDEP questions come from that material. Does not mean don't worry about the rest of the chapter, that's just the high points there. So we're going to talk about the different stages of development. It's a brief overview. We cover it a little bit more in depth in other chapters, but you need to know that there's different physical changes throughout each stage of our life, and it may impact how we approach our patient for our assessment. For our neonates, we're looking at that birth to 1 month. These are our newborns. We're going to cover neonates in Chapter 33, which is our OB neonatal care. Then we've got our infants. They are 1 month to 1 year. They really develop quickly, these guys. Their weight, normally a baby is born between 6 and 8 pounds, and the head is going to be about 25% of their weight. After about 2 weeks, they're going to start growing at about an ounce a day. They're going to be doubling their weight by the time they're 4 to 6 months, and it will be tripled usually by the time they're a year old. So if we have a 6-pound baby, by the time they're a year old, they're going to be somewhere around 18, 20 pounds. Their cardiovascular system, when they're first born, we go from that fetal circulation where it's dependent on the placenta and the umbilical cord for your circulation to independent. We now are on our own. We have our own circulatory system. With the neonates, before they're born, they don't inflate their lungs. Okay, the first breath is going to be within 30 seconds of the head appearing, and we're going to suction the mouth and then the nose. So that's going to be the first time they're going to take a breath. Usually under 6 months, they tend to get nasal congestion. Unfortunately, they are nose breathers, so when they are congested, they're going to be very irritable. They can't eat properly, they can't breathe properly, they just really get miserable. So that's a concern for their airway. Another concern is that their tongues are larger proportionately, and their airways are shorter and narrower. So airway obstruction is something that's going to be more common. Additionally, our rib cage is not as rigid yet. The bones are still the bones sort of are still calcifying. Everything's still getting proper for development. And their ribs are horizontal instead of vertical. Okay. When we BVM these patients, their lungs are very fragile when they're an infant. It does not take much to inflate those lungs, less than it takes to hold in your cheeks. Less than that. So you don't want to forcefully ventilate your neonate or your infant because you can cause trauma to the lungs or barotrauma. Their muscles are still strengthening. They're immature. There's not as many alveoli in the lungs, so respiratory problems quickly become a life threat if we're not treating them appropriately. With our nervous system, it's still continuing to mature after birth. The neonate has certain reflexes that it's born with. We've got something called a Moro reflex. When they get scared, they kind of jerk and put their hands out, spread them wide, and their fingers are wide, like it's grabbing at something. Then we have our palmar grasp. That's when we put something in the palm of their hand, they close their fingers around it. We've got the rooting reflex, where if it touches the neonate's cheek, they're going to automatically turn towards it. And then we have the sucking reflex. If you touch the neonate's lips, they're going to go ahead and try and latch on and suckle. So while the baby is coming through the birth canal, the skull is not fused together, so that will allow it to go through there. We have fontanelles. We have one here at the top of the head, and we have one in the back. You might have heard of them as baby soft spots. Be aware, don't poke the baby's soft spots in their head. So the one in the back, the posterior one, it fuses about 3 months of age. The anterior one, the one on the top of their head, it's usually somewhere between 9 to 18 months before it fuses together. When we're looking at the infant's head, if the fontanelle is depressed, if it's sunken in, it's a good indication that the child is dehydrated. Conversely, if it's bulging, we have a good indication that there is increased intracranial pressure in the child's head. And here's where they are. This is your anterior, and this one here is your posterior. We do have the mastoid and sphenoid, but they fuse very quickly. So their nervous system, we have different milestones that we expect to see in these pediatric patients or these infants. About 2 months, they're starting to track things with their eyes. They're recognizing familiar faces, mom, dad, brother, sister, caregiver. About 6 months of age, we're sitting up, and they're starting to make babbling noises, starting to make cooing noises, maybe single syllable, ma, 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 ma type of talking. By 12 months, they are now starting to walk on their own. They might be pulling themselves up, walking around a little bit. They know their name. So with our immune system, initially, when the baby is born, they're going to have some of their mother's immunities, okay? If they nurse, they also have antibodies through the breast milk, okay? It helps bolster their immune system. Then we have our psychosocial changes that begin at birth and continue on as the infant is interacting with their environment, with people. And I'm not going to sit here and read this to you guys. You can go ahead and look at it. It goes over the expected things and milestones as we mature. When we go onto a call and your caregiver, your mom, your dad says to them, the baby's crying, but it's different. It's not their normal cry. They're around these children all the time. They know the cry for when the child is tired, when they're hungry, when they don't feel good, when they want their diaper changed, when they want picked up, when they want put down. Each one of these cries sounds different, and the parents and the caregivers will know the difference. So listen to what they're telling you. If they tell you that this is not a normal cry, that this is something different, it truly is going to be. So you want to really pay attention to what you're being told. It's the only way the infant has to communicate what they need, what they want. When they're building a relationship with their caregivers or their parents, it's going to be done at a different rate. They're going to bond more quickly with that caregiver that's there with them all the time. Even if that's a babysitter, they may still bond quickly with the babysitter and slowly with the parent that's away from home most of the time because of work or obligations. So that is not unusual to occur. Bonding is based on their security. They know if I cry, if I need something, this person is the one that's going to provide it. That's why they're going to bond at different rates based on the different rates of what's being done for them. Anxious avoidant attachment is found in children that are rejected on a repeated basis. In other words, those needs aren't being met and continuously ignored. This child's going to develop this anxious avoidant attachment. Separation anxiety is different than anxious avoidant attachment. Okay, separation anxiety is a normal part of maturing for children. They don't understand the concept yet that you go away and you come back. If you go away, you're gone. They can't see you. They don't know that you're there. So they're going to have concerns with that. Okay. Trust and mistrust, again, like I said, that's based on the child's needs being met. If we're not meeting their needs, they're not going to trust us. It's going to be till about 18 months that this stage goes on. Then we get into our toddlers and preschoolers. Cardiovascular system for a toddler, about 1 to 3, or a preschooler is 4 to 6. It's not really different than that of an adult. Okay, we have the same circulatory system. What is different is the heart rate, respiratory rate, and your blood pressure. So your preschoolers, your 3 to 6, we're looking somewhere between 80 to 140 beats a minute for their pulse. Respiratory rates 20 to 25. They breathe a little bit faster than an adult does. And their systolic blood pressure is between 80 and 100. It's a little bit lower than we normally see with an average adult. They are still developing their lungs, so they're not able to continue those deep or rapid respirations for a long period of time. So if you have a child that is breathing too fast, it's going to use all of their energy stores. And in children, respiratory arrest is the main cause of cardiac arrest. So we have that child with that situation where they're breathing fast for an extended period of time. We want to try and get that slowed down, get them on oxygen, and ensure that we're controlling their respiratory to help prevent that cardiac arrest. They're not gaining weight quite as quickly as they were. They've now lost that passive immunity that they had when they were born and when they were breastfeeding. So we're going to need our immunizations now. Their neuromuscular growth, though, is becoming rapid. Those fine motor movements are starting to improve. Their coordination is improving. Most times, by about 28 months, we will have completed our toilet training. They're able to speak in simple sentences at this point. They're expressing themselves. They know what the word no means and don't like it. They've got a handle on basic language. The biggest psychosocial challenge for them is autonomy versus shame and doubt. So they want to do things on their own, but they're afraid and unsure about it. They don't want to be doing it wrong. They're starting to interact. They're playing games with other children. Usually they're going to be, either in a pre-K or a child care setting where they're interacting with other kids on a routine basis. They're starting to learn cause and effect. If I do this, if I smack somebody, I'm going to get in trouble. If I put my clothes in the hamper, I'll get praised. So they're learning that cause and effect. And they're starting to learn gender differences. Now they do that by observing role models. Is how that is done in this age group. When we get to our 6 to 12-year-olds, they're still continuing to mature at a rapid rate. Their physical traits, their functions are maturing quickly. They're growing about 4 pounds, 2.5 inches a year. They're losing their baby teeth. Their permanent teeth are coming in. Now they're starting to have brain activity increasing in both sides, in their right and left hemispheres. They're starting to understand abstract thoughts. They have pre-conventional reasoning. They learn how to act to avoid getting punished, okay, or how to act to get what they want. The pre-conventional reasoning is to avoid punishment and get what they want. Then we've got our conventional reasoning. We're looking for our approval from our peers and society. Our post-conventional reasoning is when we're making decisions guided by your conscience. They're starting to develop that conscience, that self-esteem, self-concept is developing during this stage. Their self-image also. So our teenagers, we consider them to be between 12 and 18. Their vital signs are more of that of an adult now. We're looking 60 to 80 beats a minute for their pulse. Respiratory is now 12 to 20. And their blood pressure, systolic, is 90 to 110. So they're more in that adult range. We're going to have a 2 to 3 year growth spurt. Muscles and bones are growing. Your body is changing. Usually for the girls, it's going to be done by about 16 years. And for the boys, it's going to be done by about 18. Our endocrine and reproductive systems are maturing. Our secondary sexual development is taking place. We're developing pubic hair, axillary hair. Girls are starting to develop breasts. Boys' voices are starting to get deeper. They're starting to change. Girls will start their periods, menstruation. They can have acne occurring. This is our hardest age group, I think. We have psychosocial changes. Usually there's going to be conflict between the adolescent or the teenager and the parents because they're trying to get control over their own lives. They're trying to become independent. They want to make their own decisions and to do their own things. Privacy is a big issue. They don't want you walking in their room unannounced anymore. They want to have privacy. They want respect of their own space. They're becoming more self-conscious of their appearance. They can be struggling to create their own identity. They may be looking at their public image and how people are perceiving them, how their peers perceive them. They may be exploring gender options. They want to be treated like adults as far as making their decisions, but they want to be cared for like younger children, with you taking responsibility for making sure they've got food, doing their laundry, getting them from point A to point B. So it's a really tough time, this age group, in my opinion. Your antisocial behavior, your peer pressure seems to peak somewhere around 14 to 16 years old. There are issues with smoking, illegal drug use, unprotected sex, alcohol use can start to occur at this point. Eating disorders, because they're trying to gain self-control. One of the ways they can do that is by limiting or increasing what they eat. That's something that they can control. Then we have their code of personal ethics developed. Some of it is based on their parents' ethics and values. Some of it comes from their peers. Some of it comes from personal experience. So they're trying to develop their own code of ethics, their own way of dealing with things, their own way of looking at it, their own priorities. Unfortunately, this is also the time and the group that we have a very high risk of suicide and depression because of peer pressure. They don't feel like they fit in. They're not sure of their appearance, and a multitude of other reasons. They're just a couple very, very small amount of potential reasons. We go into our early adults. We're looking at our 19 to 40 years old. Vital signs are going to be the same. Heart rate 60 to 100. Respiratory rate is 12 to 20. Systolic blood pressure is somewhere between 90 and 120. From 19 to 25, their body is functioning at its optimal level. Okay, their lifelong habits are pretty much solidified, so the older we get, the harder it is to break bad habits. While we're still in that 19 to 25, it's easier to change it. We're working at peak efficiency at this point in time. As we get older, aging effects gradually become evident. But right now, you are at your peak. You're at your best right there. Your psychosocial is going to center on work, family, and stress. You're striving to create a place in your world or in the world for yourself. We're getting married, we're settling down, we're having kids. It's one of the most stable periods of your life, despite the stress and the change. And when we hit our 41 to 60, that's our middle adults. Our vital signs are going to be the same. Blood pressure's systolics climbing up there a little bit. We're now at 90 to 140 for your average. We are starting to become more vulnerable to hearing and vision issues. Our cardiovascular health becomes a problem. We're looking at the possibility of cancer. Your rates increase in this age group. For women, we have menopause, usually between the late 40s, early 50s. We're looking at diabetes, hypertension, weight problems. Because we're more sedentary, possibly. We're not exercising quite as much as we were. We've got more stressors. Because this age group, as we'll see in just a couple of slides here, are a lot of times that sandwich group. We've got the children are leaving, but the parents are needing more assistance, so they're stuck between the two. Exercise, healthy diet can help reduce the effects of aging on us. At this point, we're psychosocial. We're looking at our life goals. Our children are leaving home. We have the physical, the emotional, the spiritual reserves to handle issues that are thrown at us throughout life. Our finances do become a concern because we're getting older, we're getting ready to retire. We want to make sure that we've got enough money to live on. We might be caring, like I said, for our children that are leaving for college, or we might be in their high school years, and we've got our aging parents that we're taking care of also in this age group. And then that's going to bring us into our older adults. They are 61 and older. Life expectancy changes routinely. Right now it is about 78 years, determined partly by when you were born and where you live. Okay. A lot of these patients have multiple medical problems and they're on multiple medications. So our hearts, our cardiovascular system, your cardiac function starts to decline because of atherosclerosis. Your heart rate and cardiac output is going to start to decrease. It's not meeting the demands of the body any longer. Your vascular system is stiffening. Your body's ability to replace the blood cells is starting to decline. Your blood volume is starting to decline. So your heart is working harder to overcome vascular resistance. Your respiratory system, the airway increases in size. The alveoli are decreasing. The elasticity and strength of the intercostal muscles and diaphragm are starting to decrease. Breathing becomes more labor intensive. It's more work to breathe in these patients. Your vital capacity is going to start to decrease. Your chest is becoming more rigid. Your bones are becoming more fragile. Your cough and gag reflexes are starting to diminish, along with your ability to clear your secretions. Our older adults are at greater risks of aspirations and airway obstructions, so be aware of that. We have that smooth muscles of the lower airway is starting to weaken. It's causing airway collapse when we inhale. It's going to have excuse me, inspiratory wheezing, lower flow rates, air trapping in the alveoli. Our older adults are more susceptible to lung infections also. With our endocrine system, our insulin production is starting to drop off, our metabolism is slowing down, our reproductive system is starting to change, hormone production for males and females gradually decrease as we age, sexual desire may diminish, doesn't necessarily cease though, okay? With our digestive system, think about when you have a really bad cold and you can't breathe. Do you really want to eat anything? Because you can't taste it. Everything tastes bland, right? So in our older patients, our taste sensation is starting to decrease. Our saliva is starting to decrease. Your body's not able to process the complex carbohydrates as well. Your intestine's ability to contract and move food through starts to diminish. Your gastric acid secretions are diminishing. We're starting to develop gallstones. They may have decreased elasticity of the anal sphincter, which is going to cause fecal incontinence. With our renal system, the filtration is starting to decline. It declines by about 50% from age 20 to 90 years. Your kidneys also shrink about 20% over the same span. There's a decrease in the blood supply to the kidneys. There's a decreased ability to remove waste and to conserve fluids in the kidneys as needed. This is part of aging. Some patients it's more pronounced than in others. With our nervous system, your motor and sensory networks become slower. We're not responding quite as quickly. We're not reacting as quickly. We have neurons that are lost, but the knowledge is not lost. The brain in weight can shrink 10 to 20% by the age of 80. So our brain is starting to shrink. It's causing more space inside of our skull, increases the risks of injuries to the brain when we fall or if we have hit our head. And our sleep patterns changed. How many people have noticed that as our parents get older, they go to bed earlier and wake up earlier? You know, they're in bed by like 8 o'clock at night and up at 4 in the morning. It's the sleep patterns are changing. So this is what I was talking about. You can see that it allows a void to occur inside the brain and the outermost layer of meninges, increasing the risk of subdural hemorrhaging if we have an injury. We have peripheral nervous sensations diminished. We don't feel as well. When we touch something hot, it takes longer for the body to acknowledge it, or if we get an injury, it takes longer for us to recognize that there is an injury and to get it taken care of. That delay can cause significant worsening of that injury All right. The slowdown in reflexes and decreased um, spatial sense can contribute to falls. When we have our foot up in the air, when we're younger, we know where our foot is in the air. As we get older, we lose that ability to determine it, and that's more likely to cause us to fall or to have traumas. Do not make the mistake of assuming every elderly patient is hard of hearing or has vision problems. If you do, I promise they will yell at you if you go in talking too loud. However, they're more susceptible to having those sensory changes. They might need a hearing aid or glasses in order to see. They may be able to see, but it might be blurred. Maybe they can only see dark and shadows or light and shadows. They may have problems with their vision where they don't have peripheral vision. They can only see right in front of them. So these are some issues that can occur. Hearing loss is more common than visual loss, and it can occur in different ranges, or it can be complete hearing loss. Usually it's going to be in those high frequency ranges that we have difficulty. So if your patient's not able to hear you as well, try changing the tone or the pitch of your voice. Talk a little bit deeper, and they may be able to hear you better. Your psychosocial changes: until about 5 years before death, most people retain high brain function. About 95% of our elderly patients live at home, usually alone. They may have financial constraints that cause them to not be taking their medications the way they should, or not being seen by their physicians as they need to be. So you want to be aware of that. They might have friends or families or a home health care aide that comes out and helps them with some of their activities around the house. Now here's a very sad statistic. More than 50% of all single women in the United States who are aged 60 years or older are living below or at the poverty line. This is where I'm talking about the medications. Maybe they're prescribed to take something twice a day, and they can't really afford it, so they're taking it once a day to make the medicine stretch. So when we're asking our questions, when we're doing our sample, one of the questions we need to ask is, do you take any medicines that are prescribed? And are you taking them as prescribed? So that we can figure out what's going on. Be a patient advocate. If you transport them, talk to the hospital and see if there's some sort of a service that they can get that will help them with it. We're starting to face our own mortality. Our friends and families are starting to die. We're becoming more isolated and may have issues with depression. So these are all things that we need to be thinking of in how we're going to treat these patients. They may impact the way that we need to do our assessments. So if you have any questions, please ask me when we're in class next. Thank you.